1 in 3 childbirth-related deaths in New York City come from Brooklyn, and data shows those deaths are disproportionately among Black women. We are 3 times more likely to die from a pregnancy-related cause than other women. Many factors contribute to these disparities: quality health care, underlying chronic conditions, structural racism, and implicit bias. Brooklyn Borough President Reynoso took this data personal and created a maternal health task force to tackle the severity of this issue. I wanted to create a safe space to have uncomfortable yet transformative conversations that move people, amplifying the voices of those who are underrepresented and who inspire positive change. I'm Toni Williams, and this is Brooklyn Savvy. You know, with Black women being 9.4 times more likely to die in childbirth, this idea of having a maternal health task force, to me, is long overdue, long overdue. So before we get started talking more deeply about it, since our Brooklyn and beyond might not know the wonderful women that surround me, we have Annette Perel, and you are a doula. And there is Dr. Hayes, you're the Deputy Commissioner of the Department of Health. And we have Helena Grant, and you are the co-chair of the Borough President's Maternal Health Task Force. Seems like a mouthful, but it's doing so much. And then, of course, there's Lisa Bing. Welcome, ladies, welcome. I wanted to just get started talking about, we hear the need, 9.4 times greater to die in childbirth. Why did we start the task force? What was behind that, Helena?
Well, we started the task force because the Brooklyn borough president really wanted to get at this issue, and I happened to have had the luxury to be his wife's midwife. One of his platforms that he always talks about is, as a public health official, he does not want to change a system that he himself does not use. And so he is so into changing the public health system for health care and for education, because him and his family utilize it. And so during those prenatal visits, quite frankly, I kept bugging him.
Right.
And I kept talking about this issue. At the time, he was the councilman. For me, as a clinician, there was no way I was going to let the opportunity aside to have an elected official be in prenatal visits with me monthly and every 2 weeks.
And not do some advocacy work. And not do some advocacy work, right.
And so, you know, he really got into it, and he was like, wow, my wife's at risk. Like, you know, it's amazing that people don't understand the risk of Black.
But does being Black put you at risk?
Or is it the system?
Yeah. I mean, how does that work?
Yeah.
Yeah. What puts you at risk?
Being Black.
Being Black?
Let's go a little.
Let's just go a little deeper with that, Dr. Hayes.
I mean,
excuse me, and I want to get back to you. Yeah.
We know that the statistics are what they are, but underlying those statistics is the structural racism that is in our country.
So then, is it really about being Black, or is it being Black in this system? Yeah, because when I hear you say being Black, I'm thinking, well, is there some physiological makeup of Black women? But it's being Black in this system.
Yeah,
yes.
it's the history of racism, the historic medical apartheid system of healthcare and of every other structure that we have.
Could you unpack that just a little bit, this idea of medical apartheid?
Well, we have a medical apartheid system where Black people make less money. Black people live in neighborhoods that are purposefully under-resourced. And I always put the word purposefully. It's just not under-resourced because people don't want to do the work. It's purposefully under-resourced. You know, we have bodegas on the corner, and Whole Foods is in other neighborhoods. And so when we look at this, we've now called the social determinants of health: housing, food insecurity, a toxic lifestyle, and the epigenetic trauma. What happened to all of of us here as women, we're holding that, and I always like to say we have issues in our tissues because of our great grandmother's trauma.
What is that? Can you would you call it
Epigenetic trauma.
Yeah, explain that, because that's a new one for me.
It means that when something happens on your family line, especially to women, up to 5 generations, it gets passed on.
Really?
Oh yes, there's
how is that
research around this.
Oh yeah, there is.
Right,
I mean,
but
there's even the basis of where they talk about the structural change in your DNA
Yes,
over time due to ongoing trauma. So what you're passing on in each generation is part of that trauma that your your ancestors may have experienced. So that's what we're talking about.
Right? Because part of it is, I can recall my mother's story when I asked her about my birth, for example, and I was her 3rd child, and she got an episiotomy, and to this day she doesn't understand why she was cut. All she says about my birth story is, they cut me, and she has no idea why. And as a doula, before I was a doula growing up, hearing that, I was like, they cut women, and then why? And there was no
wasn't that
explanation.
to make more space for the head to come out?
That's what they say, to make more space. But when you look at when episiotomies started versus when my mother got one, they were practicing, because it was in the 70s, right? They were learning about episiotomies. Midwives don't do episiotomies.
Yeah, I've caught, because I don't use the word deliver. There's no such thing as a delivery. About 2,000 babies.
You've caught 2,000?
2,000
I like
babies.
that.
And I've only cut 12 episiotomies.
Wow.
Episiotomies are totally unnecessary. They are something that was just done to hurry up when the head is crowning. It's such a beautiful thing in birth when you see a baby come out and fit through the mother like a tight sweater. But if we don't want to be patient for that to happen, and we want to pick up a scissor and cut the woman's vagina open, that's just going to destroy the tissue integrity, set her up for a lifelong thing of pain, sexual dysfunction. And the thing about the body is just so beautiful, because when the woman were to tear, the body instinctively knows how to tear and spare the nerve tissue. But if you cut, you're cutting through the muscle, through the nerve, and then you're there sewing it back up. And it's deeply problematic long term. And then when women have subsequent babies, because the tissue integrity was destroyed, a lot of times they will just split right open through the episiotomy. So it is obstetric violence. It is. Well, it is. But these are the conversations we need to have. It is obstetric violence, and it is extremely traumatic, and it's unnecessary. And episiotomy is only supposed to be done for 2 reasons. When a baby is truly big, like we're talking 10, 11 pounds, and you know that you need more room to get the baby out, or the baby's in distress and you don't have another 10 minutes to wait for the baby to be born. Those are the only 2 reasons.
Now are outcomes better when someone uses a midwife?
Well, outcomes are better when someone uses midwives that don't ascribe to what I'm going to call the medical technocratic patriarchal model of medicine, and when they use midwives who, when needed, consult and collaborate with physician colleagues if they work in a hospital system. And so there's this balance or harmony, because maybe we're never going to find balance because of history, that midwives need to be able to walk when they work in a hospital system. And then there are other options for people to give birth who have totally no medical history, no medical problems, birth centers and home birth. But that's a very small segment of the population, unfortunately, due to the epigenetic issues that we have, and due to the comorbidities and the medical problems that a lot of people are entering their pregnancies with.
And then compounded by the racism in the system.
Right.
Exactly.
What do you think about what did you call it? The medical
Patriarchal model of medicine.
You are a doctor. Not to put you on the spot, odd at all. But I always wondered, because see, I'm from that headset where I went with that, you know?
You went with what?
With the whole medical
With
technocratic.
traditional Western medicine.
I was fine with that, and the idea of a midwife seemed like I would be taking a risk. You know,
But
because
I
I didn't
think-
have, but I'm just speaking from 30 years ago because my kids are old.
Well, a couple of things. What I heard Ms. Grant say is there can be a relationship with the provider, okay? And I think that's a point that I would like a lot of people to walk away from here understanding that a lot of what we're dealing with within the maternal morbidity and mortality is only going to be solved by a collaborative effort. There's a place for the physician, there's a place for the midwife, there's a place for the doula. And the patient is the center of that, okay? So if we are not making sure we take that into account, then I think that's where the system breaks down. You asked about my role as a physician. I might not be the best person to answer that because I was always the type of physician that did not operate or practice from a hierarchical point of view. My background is one of adolescent medicine. I'm a pediatrician trained in adolescent medicine, which means all of my patients are between the ages of 11 and 21. And one of the things that I particularly talked about with my patients is that our relationship is a partnership. It is not a hierarchy. It's not one, I was not trained that I'm the doctor, I give the orders and you follow. I was trained to bring the patient into the practice, understand who that patient is in their space, and work with the patient because my optimal goal is the health of the patient. So unless I can engage, have them to be part of the process, you're not going to be successful in having a healthy patient. So yes, but I was trained in an environment where the doctor is the authority and the patient is the recipient of the
Expertise.
doctor's advice. And that is a problem. That is a problem. And I think that that's also part of why we're seeing the outcomes that we're seeing within maternal morbidity, specifically in Black populations. Because I don't think a lot of patients understand, and that is something that we are doing within the Department of Health, is educating patients on what their role is in their relationship with their physician, empowering them about how they can go into their visit and have a conversation with their provider.
That sounds like it might be challenging, though, with these hierarchical structures that you're speaking about.
Well,
Well,
because
that's another reason why within the Department of Health, we're not only working with the patient and the community, we're working within the hospitals too, because they need to be restructured as well. Yeah.
And are the doctors being trained as well?
We are doing implicit bias training, working with them as well to try to get the providers to see, because it's not only the physicians, it's all the providers, to see where there may need to be a change in how they interact with patients, how they listen to patients, how they learn from patients. Yes, all of that is part of what is the work of the Department of Health.
Can I just ask about the fact that some of these deaths are preventable, right? Is that the understanding that many of
The
these?
CDC says about 70%.
Right. What can we do to prevent them, so to speak?
A lot of the deaths are occurring because folks don't have access to care prior to getting pregnant and go into the pregnancy, unwell. A lot of times it's during the pregnancy and labor where they were not listened to, or after. We know through the statistics that most of the deaths are in New York City in particular, are happening after You know, people think that maternal mortality, morbidity is happening during pregnancy or while people are in labor. In New York City, most of the deaths are happening during the postpartum period.
Really?
And
Yes.
And how far after the birth?
Well, the CDC now requires us to look at 1 year.
Oh, wow.
The whole postpartum year. And so we're picking up a lot of deaths that way. And that's really because there's a lack of services. A lack of follow-up after for people who had hypertension, who had psychiatric issues, prenatal mood disorder, or who had substance use and misuse. We're seeing a lot of deaths in those areas. And so this needs to be a full-on movement to connect people with services and to increase specific clinician workforces around that, because we see the people most at need also had Medicaid and could not get a clinician who could care for them, who took their Medicaid insurance, especially when it comes to substance use and misuse and when it comes to mental health.
What is the task force doing? Meaning, what are your goals?
When we surveyed the Brooklyn community, we found that women in birthing people were saying they didn't know a lot of things. They didn't know where to go. They didn't know how to access which hospitals in Brooklyn had midwives. They didn't know how to access doula services. They didn't know the community resources in their own area. So we did a maternal health expo, and the Brooklyn Borough President did a marketing campaign around that. So that was number one. The second thing is the Brooklyn Borough President's transition report came directly out of the 2016 to 2018 maternal mortality and morbidity recommendations. So 2 recommendations that we wanted to focus on was increasing the midwifery workforce, because there is a space for midwives to be integrated in hospital systems where we could say, hey mommy, you have high blood pressure or you have diabetes. Let's let the physician deal with that, but this birth right here, we got this. And so that way we're not, putting more trauma, and we're working together as a team. And so we needed to increase the midwifery workforce. The third thing was back to what I talked about not having enough clinicians who treat psychiatric issues and who also treat substance use and misuse. And so was to create workforce initiatives around increasing maternal health, and specifically the psych NP workforce and people who specialize in maternal mental health, because there's just a lack around New York City about people who specialize in that. And so we have this great need. We're seeing these numbers, and when we look at the population, they don't have anybody to go to care for them.
So if you have if you're having a healthy pregnancy, what would be the role of the midwife and the doula? Meaning, is there a connection there? How does that, or does that work?
Yes, there's a role. As a doula, I work in tandem with everyone. We work as a team. It is not me and my clients against the medical system. We are getting them information that they ask. Like, I have my clients ask all of their doctors, like, what is your policy around water breaking? How far past my due date will you let me go before you start talking about induction? What if I wanted to push back? To have these conversations and have dialogues. There are people who, for example, I'll do a birth plan, and some people don't like birth plans. There was at Columbia Presbyterian last year, something went viral because a physician's office sent out letters to their clients to their patients, saying that they do not accept birthing plans. They know best.
Explain a birthing plan.
So a birthing plan is simply a statement of, it's not even a plan, it's a preference. If everything goes well, these are the things that I would like. And it's certain things that you could tell your provider, but also for the nurse as well, right? There are some things that happen during labor, for example, when it's time to push, everyone gets really excited and starts yelling. Maybe the mom doesn't want that. Maybe she wants people to be kind of quiet. Maybe she doesn't want students. That's the one thing that NYU has a birth plan. Columbia Presbyterian has a birth plan that they give out to their patients. And the one thing that's not on there is no students. And I tell all my clients, you do not want students in there working on you, practicing on you. Because practice, how it looks is, oh, you had your baby. Now the doctor's like, look, here's this stitch. Now you try. And they were not consented, and that happens all the time.
Wondering the language around birthing person. What is that? That's something new, and I was reading, and I kept finding that. Isn't that usually a woman?
Well, we now use the language women and birthing person because some people who give birth do not identify themselves as
I
women.
see. Oh, yes, yes. Thank you. We will not strike that because I am sure that there are other people out there that don't know that as well.
When you're pregnant, the last thing you want to do is fight.
Well, I'm
right?
not. Oh, well, you have to. Well, that's.
But
yes.
then that's part of
Yes.
it. Part of being
But you
able
have to have
advocate
somebody
for yourself.
advocating on your behalf.
No, you cannot, because I cannot speak on my client's behalf. I can speak up.
But can't
for
the
my
partner?
client, but the partner can. But if the partner doesn't see the disservice that's happening, there's no way they're going to know. So I can speak up in a way that gives me agency, but I can't speak for my client. For example, if my client said she didn't want an episiotomy, right? And I see that they pick up the scissors,
Right.
and they're about to give her lidocaine, I can say, it looks like they're about to give you an episiotomy. Did you discuss that? And did you get consent? And then that can happen. But
Right.
sometimes it happens in spite of that. So I can say that.
Right.
The partner's there, hears that, and is supporting it, but they cut an episiotomy anyway.
Well,
And
that to
I-
me is a whole different.
Yeah, and
animal.
I think in this conversation we have to also discuss issues like status and privilege.
Yes.
You know, I'm
Yes.
a privileged black woman.
Right.
I feel
And
very
you can
comfortable
speak up.
speaking up.
Yes.
I feel very comfortable writing a 5-page email if somebody
Thank
does
you.
me wrong.
I feel
Right.
very comfortable getting
yeah,
the
the chief
medical
medical
officer on the phone.
But a
and when we look
14-year-old
at the,
girl
yeah.
may not feel that
and
at
when,
all.
and we look and when we
Right.
look at people who are maybe a lot of folks in the population that are dealing with this also are homeless and houseless, live in shelters, have had
speak the
toxic.
language.
Yeah, that's right. We have a large immigrant population that deals with this, and so you know they need advocacy, but they don't have self agency. They haven't
Understood.
got there yet.
I can give you an example
Yeah, but I
of
think what I think we have a long way to go.
Yes.
I mean, I think this show in and of itself is a start to education. That is why at the Department of Health we have these programs to empower patients. And we also have people working within our agency that look like the population, are advocating for the population, and will continue to do that. Me being one of them. So I think as long as we are moving in that trajectory, we are nowhere near where we need to be. But we will continue to empower our patients. We will continue to educate them, because that's what this is all about. That's right. And we also are addressing within the systems some of these issues that you're talking about, because we know they exist.
I'd like to kind of dig into the role of the doula, because when I had children, that did not exist. It was your mom. Or talk to us about what a doula does and why it's going to be imperative that you're involved in terms of healthy outcomes for
So
pregnancies.
a doula provides information support, right? Comfort, and also physical support during birth. So prior to, what that looks like is I'll have prenatals with my clients where we go over what's your birth plan, what's your ideal, do you like your physician? That's the first question.
Well, that helps
do
build
you
agency.
feel comfortable
Yes,
with
it
your
does.
Yeah, that helps
physician,
build
right?
agency.
And the problem is that we're finding that when clients hire me, they're already 6 months pregnant. So being able to provide resources to clients if they come to me early and they don't like their provider, I am the connection. I am not covered by insurance. We are covered by flex spending. Medicaid, which was trying to get doulas covered. New York State was trying to get doulas covered by Medicaid, but it was an outrageous offer and ask of what they wanted to pay doulas for their services. We live in one of the most expensive cities in the world, and they were offering doulas like $500 per birth with like
over
12
a 9-month
prenatals.
period?
Huh?
Over a 9-month period?
So a doula doesn't stay with you for the whole 9 months. Most people start looking for doulas after the first trimester. But the department, I forgot what they were offering, but part of it was They wanted a lot of prenatals. They essentially were saying that we were kind of like almost, what would you call it? Like social workers in the sense, because they wanted to collect all of this data, right? But our work isn't just social work. You know, if you're thinking about New York City and you think about rents, how many births do you have to do if you're only getting paid $500 to cover $4,000 worth of rent and excess? It's not enough. All right, so we're mostly independent and freelance. We do get referrals from doctors, but we don't work with doctors. We're trained. We're trained through organizations. There are many doula organizations that are trained. You do not have to be certified to be a doula. That's one thing that is also a barrier to entry for some, because a lot of these certification organizations are just a money grab because they're not doing anything to support doulas once they're in this field. So you have to look at that as well as a doula. But for most part, my clients are all pay out of pocket.
And are doulas especially helpful with breastfeeding, helping mothers to breastfeed?
Yes, some doulas are trained lactation counselors or IBCLCs. I'm a lactation consultant. So yes, they do help with that as well. But what we're discovering too is directly after birth, we want to get the baby nursing within the first hour.
The nurse usually, during my time, the nurse was the one.
Yes, the nurse
was a long time ago.
Unfortunately, though, the nurses are overworked, right?
But I will put the plug in once again for the New York City Department of Health. We have a whole breastfeeding coalition where we support breastfeeding after birth. We have lactation consultants within the hospitals that can be referred to. So there are support mechanisms there.
There are some, but there's not enough. And the problem is that even hospitals that have lactation consultants will have two, and they don't work on the weekends. Great. And so two for the month of births that happen in New York City is definitely underwhelming, and they're not helpful. They'll go in and they're being directed. You can only say X, Y, and Z, and you got 2 minutes. You can't teach somebody to breastfeed in 2 minutes. You can't comfort someone who doesn't understand latch, who's not understanding transfer in 2 minutes of how much milk is your baby getting, how can you tell if your baby's satiated in that much time, and then they're home. We need programs that not just offer in hospitals, we need programs that offer in home as well.
Yeah, but these programs do. There are texting programs associated with it as well.
You don't learn from a text. We need physical people. Like if we look at Canada, for example, they have a program where after a woman gives birth, they get a doula, postpartum doula for 6 months that's paid. Someone that comes to their house three times a week that helps
all
with
of
problems.
That is systemic. That's in the system. The system does
you.
that.
Yes.
Right.
Thank you.
Socialized medicine.
Yes, exactly.
It is. And everybody gets access
the
to
medical
midwifery
industrial
care,
complex.
too.
Exactly.
I mean, you know,
it's very
when
challenging.
we look at the other developed countries, and I hate to use that word, or industrialized nations, what they have different is they have a lot of these services. We look at the maternal mortality and morbidity rates. We look at the increased rates of midwifery in England and France and Germany and Sweden and Canada, and it's a very integrated system.
And not like this one.
Not like this one, and also that you know, women and birthing people, you're pregnant, you by the end of the 7th month, you go on maternity leave and you get a year's pay. You know, and so it's a very, you know, it's no wonder they have less maternal deaths.
Well, I can say this. Thank you for all of you, okay? Because each one of you is a lever in trying to make this a better system. Thank you so much for all the work that you're doing, and we hope to have you back to talk more, you know, because we want to see outcomes. We want to see the outcomes change.
Right, that's right.
Alrighty.
We want Black women to live.
Exactly. That's a good place there. We want
right.
Black women to live.
That's right.
We'll see you next time on Brooklyn Savvy.